So my name's Ben Tran. I'm a medical oncologist. I'm based at Peter MacCallum Cancer Centre in Melbourne, Australia. So AMG 160 is a half-life extended bispecific T-cell engager. So what this agent does is it engages the patient's own T-cells to target PSMA on prostate cancer cells. And in doing so, it activates the cytotoxic potential of T-cells to eliminate the prostate cancer itself. AMG 160 is a half-life extended version of a BiTE molecule, and it contains these fragment FC domains, which are designed to extend the amount of time before it's eliminated from the body. BiTE technology is a targeted immuno-oncology platform that's engineered to engage T cells that normally are there to survey the body for malignant cells. BiTE immune therapies allow T cells to identify target ligands overexpressed on tumor cells. There are various types of BiTE therapies targeting PSMA, as in AMG 160, but also other targets like DLL3, BCMA, and CD19. So by targeting these cells through these overexpressed proteins, it allows for T-cell mediated killing. So we've presented preliminary results from the phase 1 first time in human dose escalation study of AMG 160. So as I said, these are preliminary results. This phase 1 study, as mentioned, involves 3 portions. One is the dose escalation or dose exploration portion, results of which we're presenting at ESMO 2020. Other components of the study include a dose expansion phase, where we'll treat a larger group of patients at the recommended phase 2 dose. And there's also a component of the study where we combine AMG 160 with pembrolizumab. Doing so because the preclinical data suggests that AMG 160 induces upregulation of the PD-1 axis. So the data we presented is from the first 43 patients treated on this phase 1 study. All these patients, as you know, have metastatic castration-resistant prostate cancer. They are quite heavily pretreated, with over 60% of patients having had 4 or more prior lines of therapy. The study we presented have shown that AMG 160, given as a monotherapy, has early and encouraging safety and efficacy data, and that shows this molecule, AMG 160, has the potential to dramatically improve outcomes in prostate cancer patients. We've shown that around 69% of patients have had any reduction in PSA, with around 34% of patients having a reduction of PSA of 50% or greater. We also have shown that these responses are durable, with 6 patients continuing on treatment for 6 months or greater. At the time of reporting, we had 19 patients still on study. We haven't yet reached or determined the recommended phase 2 dose, so the dose exploration portion of the study continues. Thus far, the safety profile has been very manageable. What we've seen is what we would expect with bispecific T-cell engagers, that being cytokine release syndrome, which is a result of successful T-cell activation. The cytokine release syndrome we've seen has been limited and reversible with mitigation strategies that we've taken on. These have included the use of priming doses, which are lower doses being given before the target dose is achieved, and also other standard interventions such as steroid pre-medication and intravenous hydration prophylactically. We've noted that 26 patients, or about 60% of patients, had grade 2 CRS as their worst grade, and 11 patients, or around 25% of patients, had a grade 3 CRS as the worst grade. There were no grade 4 or 5 CRS events, and no patients discontinued due to CRS. The mitigation strategies which we have undertaken in this study have been able to reduce the grade and severity of CRS experienced by our patients, which allows us to maximize efficacy and deliver a better risk-benefit profile. As we continue our dose exploration, we'll continue to optimize the dose priming strategy, and in doing so, we've already seen improved efficacy and ongoing mitigation of frequency and severity of CRS. The patients we've treated on this phase 1 study are heavily pre-treated and had received both novel hormonal therapies and chemotherapy prior to coming onto study. We had some patients also receive prior lutetium PSMA, with 2 patients in particular having had a response to AMG 160 after progressing on lutetium PSMA. As mentioned, over 60% of patients have had 4 or more prior lines of therapy. This is a phase 1 study, so it's really a little bit too early to say how AMG 160 will be positioned in the future. We're very encouraged by these data that we presented here at ESMO 20, which suggests that AMG 160 has efficacy and can be safely given in patients who are both refractory to chemotherapy and hormonal therapy, and even that of lutetium PSMA. Where it sits in the future in combination with alongside lutetium PSMA, it's hard to determine. The mechanism of action of lutetium PSMA versus AMG 160 is very different. The only thing they share in similarity is that they both target PSMA as a means to get to prostate cancer cells. I'm truly excited by the results we presented at ESMO 20, the efficacy and safety results of AMG 160. As mentioned, there's a combination component of the study combining AMG 160 with pembrolizumab. At this point in time, our primary goal is to arrive at a recommended phase 2 dose and initiate our dose expansion part of this study. As yet, there's been no definitive plans on where to go next. But we know that there are new therapies continuing to enter the prostate cancer space all the time, but there's this gap in terms of immunotherapy. Immunotherapy in prostate cancer, as we know it so far, has been largely disappointing. Benefits from checkpoint inhibitors in prostate cancer have seen PSA responses of 10% or less. So although these data we presented are early, the fact that we've seen 34% of patients with a PSA reduction of 50% or greater, and 3 partial responses out of 15 patients with measurable disease gives us promise that AMG 160 may be able to dramatically improve outcomes for patients with mCRPC.